So welcome back. This is part 2 of the extraocular muscles. Now I hope you went through the video that we shot yesterday. Once again, sorry about it being a vertical outlay. And sorry about dancing around so much. I was in the zone, so whenever I'm teaching, sometimes I tend to dance a lot. If you check it on 1.5x, it will be even more entertaining, I'm sure. Okay, so now that you understand the concepts, I'm going to summarize the actions. Okay, let's summarize the actions of the recti. Let's look at the superior rectus. So the superior rectus is responsible for elevation, adduction, and intorsion. The inferior rectus is responsible for depression, adduction, and extorsion. You can see that in the left-sided diagram. The medial rectus is responsible for adduction and the lateral rectus for abduction. Actions of the obliques. The superior oblique is responsible for depression, intorsion, and abduction. The inferior oblique is responsible for elevation, extorsion, and abduction. You can take a screenshot of this table. So everything I told you was basically in primary position, right? And you already know that in abducted eye, the superior rectus causes pure elevation, and in the adducted eye, it causes pure intorsion. Again, inferior rectus is just the opposite. And for superior oblique, in the abducted eye, it causes pure intorsion, and in the adducted eye, it causes pure depression. And the opposite for inferior oblique. I don't think we have to really discuss about this. You all know that the elevation and depression occurs around transverse axis, adduction and abduction along a vertical axis, and intorsion and extorsion along an anterior-posterior axis. I like this table as well. It's a different perspective on the same information. So we are doing movements and the muscles that are producing them, like how we do when we study joints. So elevation is brought about by the combined actions of superior rectus and inferior oblique in the primary position, which means that to cause pure elevation in the primary position, the superior rectus has to act along with the inferior oblique because they're both elevators, but one's ability to adduct has to be neutralized by the other's ability to abduct. Do you understand that? So the ability of the superior rectus is going to have a tendency to adduct, and that will be neutralized by the tendency of the oblique, inferior oblique, to abduct, and both of them are elevators, so then they will cause pure elevation. Okay? In the abducted eye, it will be superior rectus only elevation, that is, and in the adducted eye, elevation will be by inferior oblique only. Okay, you take a screenshot of this table and just spend some time with it and you'll understand what I'm talking about, right? Okay. Associated movements of the eyeball. So when the visual axis move parallel to each other of both the eyeballs, it's known as conjugate movements. Example is dextroduction when you start looking towards the right side, levoduction when you have to look towards the left side, superduction when you look up, subduction when you look below, and disjugate movements is when if the axes are converging, that is known as convergence. If the axes are diverging, that is known as divergence, which human beings can't do. And circumvergence, again something that human beings can't do, that is if one axis is going upwards and the other axis is going downwards. Okay, now we're going to speak a little bit in detail about the Levator Palpebrae Superioris in case it is asked for a short note. So the origin is from the lesser wing of sphenoid, you already know that. The insertion, now this is the thing, right? The superior rectus, just above that you will find the Levator Palpebrae Superioris. Both of them have a common sheath around it, but eventually as the Levator Palpebrae Superioris starts going towards the eyeball, it splits into 3 tendons. Now you have to look carefully to understand what's happening over here. Check this out. It's splitting into 3 tendons. There you go. Sorry about that. Can you see? It's labeled over the tendon of Levator Palpebrae Superioris. Now, the first uppermost split lamina can be seen inserted into the skin of the upper eyelid. Can you see that? Then the middle tendon, you can see a little bit of reddish color over there because it again has a few muscle fibers arising in it. This middle tendon is actually you should call aponeurosis, not tendon. This aponeurosis is inserting into the upper border of the superior tarsus. Can you see the superior tarsus? It's a fibrous plate that is responsible for the stiffness of the upper eyelid, right? So you can see certain reddish colored fibers inserting into the upper border of the superior tarsus, and this is known as Mueller's muscle, M-U-L-L-E-R, Mueller's muscle, and it is innervated by sympathetic fibers that travel all the way from the T1 segment. So just remember that. And the lower lamina is inserting into the superior fornix of the conjunctiva. So the superior fornix is the point where the bulbar conjunctiva continues outward as the palpebral conjunctiva. Read about it. And in the superior fornix of that is the insertion of the third lamina. Okay. Now, the nerve supply is by the upper division of the oculomotor nerve, and the action is the elevation of the upper eyelid. Okay, we'll be studying a syndrome which involves the T1 segment, which can lead to what is known as ptosis or depression of the eyelid, P-T-O-S-I-S. Study that in clinical anatomy, not in detail though. Okay, factors maintaining eyeball stability. Now remember, the anterior-posterior stability is maintained by the recti and the obliques. The recti have a tendency to pull the eyeball inwards, and the obliques, since they're pulling the eyeball outwards, both of them together maintain the anterior-posterior stability. Try to understand that if one of the recti is compromised, then the obliques win in the tug of war. So the eyeball pops slightly outwards. If one of the obliques are compromised, then the eyeball pops inside because of the recti winning the tug of war. I hope you understand what tug of war is, when two people are on either side of a rope, okay? So then there is a tendency for the eyeball going inside. These are respectively known as exophthalmos and enophthalmos, okay? Then there are check ligaments, which are fibrous thickenings that are present around the eyeball, and they also have a downward extension, which is known as a suspensory ligament of Lockwood. I would advise you to read it from the textbook. There's nothing very conceptual or difficult about that. And there's obviously orbital fat that is responsible for filling the orbit and maintaining the eyeball in a particular position. Peculiarities of the extraocular muscles, they are strap muscles. Also remember the other examples of strap muscles. Sartorius is one, infrahyoid muscles is another, rectus abdominis is another one. The embryological origin, don't go into the details, but the extraocular muscles are derived from what are known as somatomeres. These are the cranial most somites, okay? Just like the laryngeal muscles and the intrinsic muscles of hand, the extraocular muscles have small motor units. They comprise of slow twitch and fast twitch fibers. And embryologically, the levator palpebrae superioris is considered as the delaminated part of the superior rectus. Okay? Now, clinical anatomy, clinical testing. Now, this is a practical thing, so maybe I could have shot a video and included it here, but it's just something that I'll have to revise with you in class, okay? Clinical testing of all these. So we can discuss that in one of the revision practicals. Let's have a look at some of the things. Oculomotor nerve palsy. Now this is when the oculomotor nerve is compromised. Remember, the oculomotor nerve supplies the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique, okay? So if your oculomotor nerve is undergoing palsy, then the superior rectus and the inferior rectus are both compromised, okay? So दो लोग कम हो गए, है ना? ऊपर से एक ओढ़ने वाला और नीचे से ओढ़ने वाला, correct? So both of them are gone. So the net effect is still neutral. But then there is also inferior oblique. Now inferior oblique elevates, right? So because the inferior oblique is gone, the superior oblique wins the tug of war. So there is a tendency to depress. Remember, the superior oblique is a depressor. So the first thing is down. And the other thing is the medial rectus is gone. So because of the unopposed action of the lateral rectus, the eyeball is also gone out or abducted. So that is known as down and out. Okay. Of course, there is ptosis because of the involvement of the levator palpebrae superioris, and there is also apparent proptosis because remember, the recti hold the eyeball inside, and that is compromised. So overall effect is that the eyeball is going to be popping out. That's known as proptosis. Don't worry about the other things. The loss of accommodation is something we shall study in the ciliary ganglion and in neuroanatomy again. Okay. Trochlear nerve palsy. Now this supplies only superior oblique. What does the superior oblique do? It causes depression, abduction and intorsion. So depression is gone, so there will be a tendency to elevate. So you can see the right eyeball is affected over here, it's elevated, and abduction is gone, so the eyeball is going to be adducted. So you can see that the eyeball is elevated and adducted because of the unopposed action of the other muscles. Okay, that's all you need to remember for now. The abducent nerve palsy, this is a no-brainer. Lateral rectus is compromised, so the unopposed action of the medial rectus will lead to the eyeball going medially, which is also known as internal strabismus. The most common cause is increased intracranial pressure because the abducent nerve arises from the pontomedullary junction. Anyways, that is something you'll study in your brainstem and neuroanatomy. And the last thing is Horner's syndrome. Now, I don't want to talk about details, but just remember it consists of ptosis, meiosis, anhydrosis, enophthalmos, and loss of ciliospinal reflex. The only thing I would like to discuss here is ptosis, because the fibers that are originating from the T1 segment are climbing upwards and eventually reaching the Levator Palpebrae Superioris. Its involuntary component, which is also known as Mueller's muscle. Correct? So T1 segment, the commonest cause of T1 segment being affected is a lower trunk injury, which leads to Klumpke's paralysis. So Horner's syndrome is one of the signs of Klumpke's paralysis. It could also be because of a cervical rib, extra rib, because of which there is a pull on the lower trunk of the brachial plexus, and that could lead to T1 root being affected. So anyways, you will obviously study this more in detail. All the other things like meiosis, anhydrosis and ophthalmos, all that will be considered when you understand the autonomic nervous system. No point in going in details over there. Okay, that's for another lecture. But thank you so much for listening. The video is smaller compared to yesterday because I know yesterday's was a bit long, so to make up for that. Right? So yeah, what you see here is some circumvergence or whatever. Yeah, that doesn't really exist. So I hope you guys are understanding these videos. Please post in your comments if there is anything you would like me to do. If there's anything that is not understood, if you find out some error, please let me know in the comments section. And I'll see you in the next video. Take care. Bye-bye.